everyone. My name is Emily, and I am the community manager here on TuDiabetes. And it's a lovely Tuesday morning here on the West Coast in California. And I'm joined today for an interview with Dr. Osama Hamdy, who is the co-author of a recently published book, The Diabetes Breakthrough. So we're here today to learn all about that book. Welcome, Dr. Hamdy. The camera is on you. Thank you so much for taking some time to be with us here today.
It is my pleasure, Emily, and I will love to share all our experience with your audience.
Wonderful. First off, before we get into the book, we'd love to know a little bit about you. So who are you and what do you do?
You know, I'm a diabetes doctor for almost 30 years. And I came from a family, everyone in the family has diabetes. And most of my family are also overweight. So we're able to see that this is a problem everywhere. I grew up my early life in Egypt, and I had been with Joslin Diabetes Center for the last 17 years.
All right, so you have clearly a lot of real personal connection to diabetes. So when did you start to think about writing this book with Sheri Colberg, and how did that process go along to its completion now the book is available?
Yeah, you know, the book is based on our successful program at Joslin Diabetes Center. It's called Why WAIT program. We have been doing this program for almost 9 years. And we have seen very good results. I will share some of the results with you in a few minutes. But it came to our mind, actually it was a suggestion from the Harvard Health publication to write about the book and make it available for everyone across the nation. Because not everyone can come to Joslin and get benefit from this program.
What is the Why WAIT program?
Okay, Why WAIT is Weight Achievement and Intensive Treatment. So WAIT, Weight Achievement and Intensive Treatment. The program is a 12-week program. It is a multidisciplinary program. We run the program in a group, each group between 10 to 15 people. And they go through a lot of changes in their dietary plan, behavior modification, exercise program, medication adjustment, and education. It is a very intensive program for the 12-week week. We started the program, as I mentioned, in September 2005. So far, we had 46 groups completed the program. They lost in total 9,300 pounds so far.
That's pretty amazing. So in the book, you describe sort of the 12 steps that go into this program. Can you give us an overview of what the book says for people to do in order to help their health with diabetes?
The book is a very simple way of introducing the Why WAIT program so people can do it by themselves. We start week by week, and every single week we tell the reader what exactly he or she should do, from dietary plan to exercise plan to behavior change, as well as some education material and also some nice story from some of the previous participants in the program. As I mentioned, this is a scientifically based program. It is based on 15 years of research. So a lot of new information, a lot of innovative ideas people will see in the book, and it has been working very well in our practice.
If we go through the book chapter by chapter, I see that you also have a copy of the book there behind you. I wondered if you could tell us just sort of in broad strokes, sort of the directions in each chapter in each week, just as in a general sense. What are the dietary elements of the program? What are the exercise-related elements of the program? Just so people can get a better idea of exactly how it works.
Yeah, the dietary intervention in the program is very unique intervention. It is based on the Joslin Nutrition Guidelines, which was developed in 2005. And in these guidelines, we actually providing a comprehensive medical nutrition therapy. The dietary plan that will help people to not only control diabetes, but lose weight in a very good way. We are not significantly cut the caloric intake down because we aim for long-term maintenance of that weight loss. So we need the compliance to be at its maximum. And at the same time, we provide people with menus. The menus are structured menus. It has all the information, cooking instruction, nutrition facts, and all based on the nutrition guidelines of Joslin Diabetes Center. In general, we are reducing the level of the carbohydrates down to around 40 to 45%, and we're also reducing the glycemic index of the carbohydrates. We increase the protein a little bit up to help maintaining the muscle mass. We change the fat a little bit, and we reduce sodium and we increase the fiber. But the most important in this dietary plan, we designed it from the food that people eat every single day. So people will not eat some exotic type of food or they have significant restriction. They will eat the food that they usually eat, but we change it a little bit, the composition of that food to meet with the guidelines. The exercise program is balanced and graded exercise program, so it is gradually increasing week over week until we reach at the maximum around 60 minutes of exercise per day, most days of the week. And it's a combination of flexibility exercise, aerobic exercise, and strength exercise. And in every week, we add one behavior tip that will help people to deal with craving, hunger, dining out, mindful eating, relapses. All this cognitive behavior tools are described very well in the book, chapter after chapter until the end. And then in the last chapter, we are talking about maintenance of the weight loss and what are the keys that we know over years that will help people not only to lose the weight, but also to maintain the weight loss for long duration.
We have a few questions already, but one of the things that you've mentioned a couple of times is that the goal of the book is to help people lose weight and keep the weight off. And I think we all know that it's really common to work really, really hard to lose weight and potentially succeed at it, hopefully, but then gain the weight back eventually. So my first question is, why does that happen?
Usually I receive this question from a lot of people. Why 90% of people regain the weight back? Let me make it very simple and very clear. When you lose weight, you also lose muscle mass. And every time you lose 10 pounds, 3 pounds are muscle mass. Once you lose a muscle mass, your resting metabolic rate starts to go down. And if your resting metabolic rate starts to go down, and you eat exactly what you had been eating before, you start to gain most of that weight back. But when you gain the weight back, you don't gain the muscle mass. You gain mostly fat. So when people repeat this program several times, they lose muscle mass, they gain fat mass, they lose muscle mass, gain fat mass. This is a yo-yo wave. I have to
interrupt for just a moment. I'm sorry, but this is a terribly frustrating story. This is an infuriating story that you're telling, and I know that so many people struggle tremendously with it. So this plan in your book aims to stop that yo-yoing weight, right?
Exactly, and the method to do it is to maintain the muscle mass during weight loss. And there is a lot of techniques to maintain the muscle mass at very high level. We were able to see by the end of the program the ratio between muscle mass to the fat mass going up, not going down. Most of dietary plan, the ratio goes down, not up. So people maintain the muscle mass, energy expenditure at higher level, resting metabolic rate at higher level, and this allows people to maintain the weight loss for longer duration. The technique that we use is to provide more protein from healthy sources during the program and train people to do certain exercises like strength exercises. We are using stretch band or some light weights and gradually increase the level of strength exercise over time. So people build muscle mass and maintain the muscle mass. We measure their body composition at the beginning of the program and at the end of the program, and sometimes in the middle of the program, to be sure that they maintain their muscle mass. If any program help people to maintain muscle mass, I guarantee there will be a long-term weight loss.
So we have a couple of some diet-related questions for you, and also some exercise-related questions. I'm gonna start with this diet-related question first, and that is that in your book you specify, and you mentioned it, about 45% of calories from carbohydrates, and there are a lot of folks in our community on TuDiabetes who try to eat a lower percentage of carbohydrate in their diet and go higher on fat and protein, and feel like they have a lot of success with that, not necessarily in terms of weight loss, although that can certainly happen as well, but particularly in terms of blood sugar maintenance. So what would you say about going lower carb for blood glucose maintenance in both types 1 and 2?
In general, diabetes is a carbohydrate intolerance disease. So definitely you need to cut the carbohydrates down. And as you cut the carbohydrates down, you have two benefits. The first benefit is that you will get the blood sugar lower. But the second benefit is that the weight loss and the visceral fat, the intra-abdominal fat, the dangerous fat, start to go down. I agree that we need to cut the carbohydrates even lower. But in the program, because it is for a bigger audience that they cannot cut their carbohydrates way down, we kept the carbohydrates around 40–45%. But I personally believe that even if people can tolerate to go lower than this, I will not say very low, but lower than the 40%, they can even do it. The point is, which is more important, is that they need to cut the glycemic index of the carbohydrates down. So it is not just the carbohydrates, but also the source of carbohydrates is very important. I encourage people to download some of the glycemic index tables. We have them in the book as well, and try to eat carbohydrates from lower glycemic index. If they eat lower glycemic index or increase fiber, in reality they don't have to cut significantly on the carbohydrates. But again, if people would like to cut the carbohydrates down, it is fine. But if they will increase protein and fat, they have to be very careful what type of protein and what type of fat. Because not every fat that you increase will be beneficial, and not every protein that you will increase is beneficial. But this is a diet that had been used even before the discovery of insulin. Lower carbohydrates and higher fat and protein.
Mm-hmm. So what are some examples of sort of good fat and good and bad protein?
Okay. We judge the fat based on its impact on bad cholesterol and good cholesterol. The bad, which is called LDL, and the good, which is called HDL. So the best fat that can raise the good cholesterol and lower the bad cholesterol is what's called monounsaturated fat. This fat comes from several sources: olive oil, canola oil, avocado, and nuts. So people eat this types of food. This is a very good fat because that fat will help their cholesterol, lower the bad, and increase the good cholesterol. There is one other fat which is extremely dangerous. It's called trans fat. So trans fat is a hydrogenated oil. That's what you find in margarine and synthetic butter. And this type of fat increases the risk for heart attack because it increases the bad cholesterol and lower the good cholesterol. So it is exactly the opposite. And then you have 2 or 3 other different types of fat. You have what's called plant oil, which is polyunsaturated fat. This is a corn oil, sunflower oil, vegetable oil, only except palm oil and coconut oil. That type of fat lower the bad cholesterol, but again, it lower also the good cholesterol. So it is beneficial, but I will say mostly neutral. Yeah. The other type of fat is saturated fat, and this is a lot of debate about saturated fat. We have been telling people for years, cut the saturated fat significantly down, less than 7%, and this is the animal fat, the yellow fat. But observational studies and clinical trials showed that not all saturated fat are exactly the same. So fat that come from dairy products like yogurt, milk, and cheese doesn't actually increase the risk for heart attack. But the fat that increases the risk for heart attack is the fat in meat, and especially in processed meat. So processed meat like hot dogs, luncheon, salami, pastrami, all this processed meat is extremely dangerous because that saturated fat is a problem. Clinical trials showed also that if you change some of that saturated fat with polyunsaturated fat, vegetable oil, or monounsaturated fat, the risk for heart attack starts to go down. So I will encourage people, if they would like to increase the fat, is to increase the fat from plant origin, and if they use fat from saturated fat animal origin, only dairy products and cheese, and then reduce the amount of fat from meat and omit entirely the fat from processed meat. And then the last 2 types of fat is the cholesterol and the omega-3 fatty acids. So we have been also telling people for years, reduce the cholesterol intake, egg yolk and organ meat, but the reality, its contribution to the cholesterol in your blood is very little, because most of the cholesterol is produced by the liver. So if you produce that much cholesterol by the liver, you need to take statin to reduce the cholesterol down. Cutting it in dairy and diet will not make huge impact, especially that cholesterol is not absorbed very well from the intestine. But the most important part, which most audience don't know, is that it is not the cholesterol itself, it is the fat with the cholesterol. So if you are eating polyunsaturated fat, oil, with a cholesterol, it will not raise your cholesterol up. If you eat it with saturated fat, your cholesterol will go up. So let me give an example. If you fry an egg, and you fry the egg in olive oil or in corn oil, your cholesterol will not go that much as if you fry it in butter or margarine, which has saturated fat. So this is just an example. And then the last part of fat is what's called omega-3 fatty acids. And this comes from fish. And interestingly, we know that it will reduce the triglycerides in the circulation. But trials that supplemented omega-3 didn't show any improvement in cardiovascular outcomes, which means that supplemental from outside is not needed. And people may just eat fish twice per week, and that will be more than enough. So that's why, you know, it is a whole big issue to explain. So it is not any fat. They have to be very conscious about the source of fat.
And is all of the information that you just explained about different kinds of fat in the book as well?
No, that's exactly true. And that's why we say it is quality of fat and not quantity of fat.
Nice. So we have someone in the chat room who is saying that he actually gets a lot of his fat from animal sources, which we tend to think, as you said, is not the healthiest kind of fat. But his cholesterol is pretty fantastic. So are there other things that contribute to our overall cholesterol, or is it genetic? There are folks who are vegetarians who have high levels of the bad cholesterol, and people who eat a lot of meat who have really low levels of bad cholesterol. How does that happen?
You know, this is a very complicated question. You know, cholesterol is in your genes. So if you have the family history and you have the genes, your cholesterol will be high, whatever you do. And the only way to reduce the cholesterol down is to take statin. Dietary intervention, weight loss will not change the LDL that much. But regarding your audience here about the saturated fat and the cholesterol level, as I mentioned, saturated fat raises the bad cholesterol, but also in the same time raise the good cholesterol. So when you eat saturated fat, both of them are going up. So the end results will not be that bad. But the point is, not every saturated cholesterol work the same. Saturated cholesterol from processed meat will raise the risk of heart attack, but saturated fat from dairy products will not. The other part is that cholesterol, bad cholesterol itself, there's two types. One is what's called the small, dense LDL. This is a dangerous type of LDL. And there is another part which is called large, fluffy LDL, which is not dangerous. So in reality, some of the saturated fat raise the large, fluffy, not the small, dense LDL. So it is a very complicated point. What is the impact of fat on your cholesterol?
It sure is. No wonder we all get confused about this. It is really complex. So let's give the dietary stuff a break for just a moment, because we had an exercise-related question in the chat room from Anthony a while ago when you first mentioned the exercise aspect of the Why WAIT program. And Anthony's question was, how rigid is the program in terms of exercise? For example, can somebody who has certain physical limitations on the exercises they're able to do still follow the program, or are there ways to modify it for anybody regardless of their physical ability?
You know, the exercise program in the Why WAIT and as described in the Diabetes Breakthrough is the simplest and easiest exercise program you can ever do in your life. It's very simple. We have more than 20% of our patients in the program above age 70. We have one patient completed the program at age 81 and one at age 87. So you can imagine we have a lot of adaptation. But let me make it very simple. Your body is not looking for a very long bout of exercise. Your body is not looking for very extensive, vigorous exercise. Your body is looking to the sum of the duration of exercise per day. So for example, if you do 10 minutes in the morning, 10 minutes at lunch, 10 minutes in the evening, your body will look to this the same way as if you did full 30 minutes in continuous way. In reality, clinical trials that compare the short bouts with long bouts found that people who do short bouts all over the day, they do more exercise and they lose more weight. But people need to know that you need to do 3 types of exercise: flexibility exercise, aerobic exercise, and strength exercise. So in a simple way, you can do in the morning 10 minutes of stretching, flexibility exercise when you wake up in the morning. Anyone can do. This is similar to the school exercise. At lunch, you eat your lunch and walk for 10 minutes. We prefer fast walking, not leisure walking. And then in the evening, in front of the television, have a stretch band in your hand while you are seeing the TV, and do with a stretch band for another 10 minutes. When you get excited, you can do more with a stretch band, and 10 minutes. So 10 minutes, 10 minutes, 10 minutes, this is 30 minutes. Per week is 210 minutes. Someone, may say, I like dancing. Dancing is a very nice aerobic exercise. Put 1 or 2 songs and dance for 10 minutes. Someone would like to bike, to swim. These are aerobic exercises. Someone can use weights. You don't have to do all the external exercise by your feet if you have problem with your knees or ankle, but you can still do it by your hand. It is a very simple, and in the book, we explained in very nice illustrations every single exercise that you can do. You will be surprised that people with a stretch band can do more than 50 types of exercises.
So David in the chat room is asking, at what point, in terms of duration of aerobic exercise, at what point does one gain benefit? What if you only had time for 5 minutes? Is that still of benefit, or is there a minimum amount of time that you have to do aerobic exercise to benefit from it?
Yeah, 10 minutes is better than 5. 5 is better than 1 minute. 1 minute is better than 0. But I usually recommend the people to, when they do shorter periods of exercise, to have 10-30 seconds at fast speed. So when you do 5 minutes or 10 minutes, at least 1 or 2 times, 10 to 30 seconds, you do it at very fast speed, and then you slow down again. So you'll get very good benefit from that type short duration of exercise. But in exercise count.
That's really heartening to know, especially for folks who maybe feel like in order to sort of officially exercise, I have to go to the gym and I have to run like crazy on a treadmill for an hour, and sometimes it can be really daunting and feel like that is an impossible task, but 10 minutes probably is a doable thing. So my next question for you in the chat room here is, what do you think of yoga? What kind of exercise is yoga? It's stretching, but it also gets your heart rate up, and it also involves using a lot of muscles. What would you consider that?
Yoga is very important, and in the diabetes breakthrough, we have a lot of demonstration of yoga exercises that we do in our program. We teach participants to do yoga. So yoga is combination of stretching exercise and strength exercise. So if people would like to define it, it is strength and stretching, but it is not aerobic exercise. Some of the yoga positions are very, very important, and it increases flexibility, reduce the injury level in people who are doing even aerobic exercise after that.
Linda in the chat room is asking about Tai Chi, kind of along those similar lines. It's a form of exercise that is slow and very mindful. It's not running or lifting weights. But what kinds of benefits can you get from Tai Chi?
Your audience are asking about all the exercises I described in the book. We actually added this type of exercise because a lot of people from China and Southeast Asia, they love that type of Tai Chi exercises, and it is very good flexibility and strength exercise at the same time. And we teach people in the program. The bottom line, do whatever you like to do, whatever you love to do, but make it a routine in your life, and make many varieties of exercise so you will not feel at any time you are bored from exercise. You need to enjoy it. Do it with a body. Do it by yourself. Do it when you are waiting for elevator. Do it when you park your car. When you go upstairs, downstairs. It is everything is counted here.
That's fantastic. That is very hopeful, positive news, I think, to all of us who try to get enough exercise and sometimes find it difficult to do. So Sarah, actually a while ago in the chat room, was asking who is your program aimed at? Is it specifically only for people with type 2 diabetes? Can people with type 1 diabetes also benefit from it? Who is it for?
The program is for everyone with diabetes, type 2 and type 1. We have more than 20% of participants in the program are type 1. And also it is very suitable for people with pre-diabetes and people at very high risk to develop diabetes. So if you have some family history of diabetes, you are overweight, it is very suitable for you. Anything that can be done for people with diabetes can definitely benefit anyone who don't have diabetes. At least it will help them to prevent diabetes. In the diabetes prevention program, lifestyle intervention was able to prevent diabetes by almost 58%. So it is better than even taking medications to prevent diabetes.
So what exactly defines pre-diabetes? That's a term that we hear, but I think for a lot of us it sort of feels like kind of an ambiguous term. How do you diagnose someone with pre-diabetes?
86 million in the US now have pre-diabetes. So it is a very large number. 29 million have diabetes and 86 have pre-diabetes. So to diagnose pre-diabetes, very simple test. People can ask their primary care physician to test what's called A1C. A1C. And A1C is a parameter that can be used now to diagnose diabetes and pre-diabetes. So normal number is less than 5.7. And diabetes is diagnosed at 6.5. So if you have A1C 6.5 or above, you have diabetes. So between 5.7 and 6.5 is what's called pre-diabetes. You are in the sideline. Most people with pre-diabetes can develop diabetes within few years. Some of them may not, but the majority develop diabetes over time. The other test that can be done is fasting plasma glucose. So they come fasting, they measure the plasma glucose very early in the morning. Again, normal number is less than 100. Diabetes is above 126. And then between 100 and 126 is what's called pre-diabetes. There is a third test called oral glucose tolerance test. Again, you come fasting, you drink water with 75 grams of glucose, and they measure the blood sugar in the plasma glucose in 2 hours. Again, this number, normal number, is less than 140. Diabetes above 200. So if it is between 140 and 200, this is also called pre-diabetes. So in any way, you can define diabetes, pre-diabetes, very easily by one of the 3 tests.
I have a personal question that I'd like to ask you. How awkward and weird. But you had mentioned at the very beginning that there is a lot of diabetes in your family. And so I wondered if you take the glucose tolerance tests periodically to check on how you're doing.
Oh, I always do. But not the oral glucose tolerance test. I measure the A1C, and I also measure my fasting plasma glucose each now and then. I was diagnosed at one time with pre-diabetes, but I was able to prevent it so far. And I'm in normal scenario now. Good.
We have a member in the chat room whose handle on TuDiabetes is die or beat this, which I think is really clever. And that member is saying that they've had trouble getting their A1C below 8. It's been lingering around 8 for a long time, and they're wondering what they can do to try, and I'm sure that this person has tried all kinds of things, diet and exercise and all this stuff that we know is helpful. What might be some sort of last oomph that can be thrown at this effort to bring the A1C below 8? And also, is it dangerous to have an A1C that is at 8 for several years running?
I will answer the last part first. It is not recommended that to keep the A1C high for long duration because diabetes is like termites. If it is not controlled, it will cause significant damage little by little over time. You don't feel a lot of symptoms, but over time, complications from diabetes are a problem. So I don't recommend that. And we aim to get the A1C less than 7%, but in some people we can even go lower to 6.5, and in some others we can just be happy with 7.5. But 8% or above is way high. The first part is a complicated part because we need to know for how long that person has diabetes, and also what types of medication that person is taking. Let me make it simple. If you have diabetes for short duration, you can even reverse all the course of diabetes or even get remission from diabetes if you lose weight. Because during that period, your body resists insulin, and insulin is still high. If you lose weight and you become sensitive back to insulin, you may get rid of this type 2 diabetes for sometimes unless you gain weight back. But if you have diabetes for longer duration, there is actually some damage occurred in the pancreatic beta cells, the cells that secrete insulin. And in that scenario, insulin is almost needed. But weight loss in general at any stage of diabetes can help a lot. And the reason is very simple. When the muscles are active, it takes the glucose out of the circulation without any need for insulin. So active muscle is very important. Cutting the carbohydrates, as we mentioned several times now, is very important, especially if you reduce the glycemic index and you increase the fiber. So there is a lot that can be done from medication perspective, from exercise perspective, from dietary perspective, and based on his duration of diabetes and the number of medications.
We have another question in the chat room. This is David asking, he wrote, this is his standard question because this is of particular interest to a lot of folks on TuDiabetes, and that is, what's your feeling about early intervention with insulin for people with type 2 diabetes?
Yeah, early intervention with insulin is clearing what's called glucose toxicity. So when you have high blood sugar, you have what's called the glucose toxicity, especially if the blood sugar at the beginning is above 300 or more. In reality, when the blood sugar is that high, it will, I would say, temporarily knock down the pancreatic beta cells. And once you clear that glucose toxicity quickly, especially using insulin, you may revive back those beta cells. The beta cells start to work again. But this is only limited to those people who have glucose toxicity at the beginning of diagnosis. So people who get diagnosed with blood sugar in 300, 400, type 2, I prefer that maybe they will get insulin for a very short period of time just to clear the glucose toxicity. And after that, they can be just on oral medication. It is not insulin for life. It is not forever. It is just for a very short period, maybe a few weeks until glucose toxicity cleared up. People who present with diabetes with modest increase in blood glucose level, they don't have to go in that direction. Maybe they lose weight, and maybe some medication like metformin can be beneficial for them.
Mm-hmm. What about folks who have type 2 diabetes and are not overweight? We have a lot of community members with type 2 who are quite thin, and even people who are really active, who run marathons, all kinds of stuff, and who have to take insulin for type 2. Do you have any thoughts about, is it possible for those folks to ever reverse back to not needing insulin, or barring the option of losing weight, is that not going to happen for them?
Yeah, the majority of those people actually don't have type 2 diabetes. They get diagnosed with type 2 diabetes because of their age. You know, they develop diabetes in 40, 50. But there is one type of diabetes which is not common, and most people don't know about it. It's called LADA, latent autoimmune diabetes of adults. So basically, those people is exactly like type 1. There is a small damage in their pancreatic beta cell over time. And when that damage reach a point in their life, could be at age 40, 50, they start to show up the picture of diabetes. They look exactly like type 2 from age point of view, but from pathology point of view, it is actually an autoimmune type of diabetes. And when we test their blood for antibodies, frequently the antibodies are positive. And this scenario will be treated similar to type 1 for most of the cases.
So right now we have run out of questions in the chat room, but I have some other questions sort of that I made a note of. And one of them is along these same lines. For people who do not have LADA but definitely do have type 2 diabetes, are there folks who can be on insulin for some period of time, even more than just that short period of time that you mentioned to clear out glucose toxicity, but maybe for a few years, and through lifestyle changes, weight loss, or more exercise, or those kinds of things that are in your book, The Diabetes Breakthrough, can eventually be able to stop taking insulin even after some period of time of taking it?
Yeah, you know, lean population has been evaluated in clinical research for a long time. And researchers found that most lean people with type 2 diabetes have problem with their pancreatic secretion of insulin. So they are unlikely to, if they are on insulin, to stop insulin. But overweight and obese people who have been on insulin, they are more likely to stop insulin or reduce insulin. Like, for example, in the Why WAIT program, people on long-acting insulin reduced their dose from 60 units average to 27 units average. They reduced the short-acting insulin from 54 units average to 24 units average. And 21% stopped their insulin entirely. Once your body becomes sensitive back to the insulin, you will be like a hybrid car. You need less insulin to do the same job. So the chances are more with overweight and obese, and a little bit less in lean population with type 2 diabetes.
All right. I'm just looking in the chat room for any final questions, and I think you have shared so much information with us. I think people need to get the book so that they can review what you've said, because there's been so much in this. This has been a really rich talk, and I want to thank you heartily, Dr. Hamdy, for your wonderful work and for your time today. And I hear that you are headed off to China after we finish this talk. Can you just, before we finish up, tell us how you're sharing this program, the Why WAIT program that's outlined in your book, with people all over the world?
Yeah, the Diabetes Breakthrough now is translated into Chinese. So it is very popular now in China. And many centers would like to start a Why WAIT program. We have also Why WAIT program in Russia. And we are about to implement Why WAIT in the future in Mexico as well. So I hope that this wonderful work that we did with 15 years of research and 9 years of clinical experience in this field reach every corner of the universe and help people with type 2 diabetes. It is a global problem. Weight and diabetes is still going up everywhere, not only in the United States. So it is a moral mission everywhere we would like to achieve. And Joslin mission is to help people to cure diabetes and get rid of diabetes and if they still have diabetes, to live healthy with diabetes.
We actually just got another really good question in the chat room.
Okay,
Just about to wrap us up, but I can't ignore this one. This is a question from Rich in our chat room who is saying, you know, a lot of parents of children who have type 1 diabetes know what is healthy food and what is not healthy food, but there's a really difficult issue with kids and teens, and maybe just people in general, with trying to motivate them to eat really healthily. Do you have any suggestions for parents of kids with diabetes for how to help them to teach their children to eat well and teach them the importance of it?
You know, in general, kids have a big advantage. They have higher resting metabolic rate. They are more active. So we don't need their growth to be impaired, but we need to try to let them avoid certain types of food that can cause big problem. The first is the sweetened beverages. From 1977 till now, the consumption of beverages, sweetened beverages, went up 8,830 times higher. So we need to cut this as much as we can. Kids get easily addicted to the caffeine in these beverages, and they're actually looking for the caffeine and consume significant amount of this sweetened beverages. So if they you know, avoid this, number one, and then the high fructose corn syrup sweetened candies. Again, this needs to go significantly down. And don't make you know, pizza and pasta is major food that kids consume. You know, there is a, you know, they have to start, you know, to know that there's something called salad, which is very good. There is something called vegetables, which is very good. There is something called the nice chicken, not fried, which is very good also. And there is nice sandwiches that they can do and enjoy that has some good protein, turkey or chicken or even eggs. That will be fine. Cheese even is not bad for them. They like it. So there is a lot that they can do, and not abruptly prevent all of those for them, but gradually, you know, try to do it. I did with my kids. I stopped them from drinking any caffeinated beverages first, and then I found over time that they are not drinking. Most of them are drinking water now when they go out, and they enjoy it. So I hope this can help.
Drinking water when you're thirsty, that's just crazy. I'm kidding. You know, I think something I think about in terms of kids is also, it seems like, at least in the United States, and I'm guessing in a lot of other countries as well, we have a concept that children have to eat different food than adults, that there's kid food, and that tends to involve really sugary stuff, like a kid breakfast might involve flavored instant oatmeal that has a lot of sugar in it, or Pop-Tarts, or, you know, something that's probably different than parents are eating. And I think in some places kids eat what adults eat, and so if adults are eating scrambled eggs or salad, or, you know, that kind of healthy food, that's what children eat as well. What do you think about the concept of kids food versus kids just eat what everybody eats, what adults eat?
You know, in general, kids burn calories at higher rate. So I'm not worried about what the content as much as I'm worried about the amount. If the amount goes down, and especially the amount of sugar and also salt, because those are two types of tests that we teach our kids over time to do it. So if we reduce that test from the beginning, the salt and the sugar and the portion, but let them enjoy what they would like to eat, and encourage them to do more activity. I think the activity can burn all those calories, even if they are consuming some of the bad choices. They see their peers in the school eating different types of food, and they will feel psychologically a little bit withdrawn if they are preventing them entirely from certain types of food. I don't like the whole concept of kids' food, because we think that kids' food should have a lot of carbohydrates, a lot of sugar. I agree 100%. This term should be eliminated entirely. In front of the TV, kids are seeing a lot of advertisement for processed food and easily made food and fructose corn syrup sweetened food. I think this all need to go significantly down, and the media has to be very, very careful about that, because they are damaging this generation. Just for your knowledge, kids who are born in year 2000, their chance in their lifetime to develop diabetes is 1 in every 2 or every 3. 2 among white population, 3 among white population, and 1 in 2 among Hispanic population. So they have to be very careful. This is the first generation will have shorter lifespan than the previous generation. We have 18% of the kids and adolescents are obese now. Many of them have pre-diabetes. Some of them already have type 2 diabetes. So we need to pay a lot of attention to this up and growing problem. Take the video games out of their hand and the cell phone out of their hand. Allow them to go to the backyard or the front yard with their friends and have more activity. This would be even much better. Get them used to exercise and doing activity and enjoy it more than just sitting in front of the TV or video games and eat.
Awesome, awesome words of wisdom. All right, Dr. Hamdy, thank you so much for your time today. And again, since we strayed off topic a little bit at the end there, although that's a really important point about raising the next generation, hopefully, of healthy people. Dr. Hamdy is co-author of this wonderful book, The Diabetes Breakthrough, which is full of incredibly practical and doable plans for helping folks who have diabetes of any type. Thank you again for your time today, Dr. Hamdy. This has been really edifying, and we much appreciate your efforts.
It is much pleasure, and I hope everyone will enjoy the book and get us some feedback.
Wonderful. Thank you. Have a safe trip to China.
Oh, yes, of course. Thank you very much.
Bye-bye.